capsulitis. Our objectives are to define adhesive capsulitis in a clear, concise manner, review the causes, provide signs and symptoms, introduce likely tests and measures, and review the rehab process, discuss and differentiate similar diagnoses, and discuss likely outcomes. Adhesive capsulitis is frozen shoulder, literally. I just think of it as something being in an ice cube and it can't move. It appears as more pain and less mobility of the shoulder. Its lack of use results in a thickened shoulder. So on this right hand side, you can see this is the tissue over it, and that's the part that becomes inflamed. It's pain and it's stiff. It's a strong connective tissue, which is here, and it surrounds the joint. It becomes adhesive capsulitis when it becomes thick, stiff, and inflamed. And just to review some anatomy, the joint capsule attaches to the humeral head to the glenoid. So right here, the glenoid is covered by that connective tissue, but behind it is the glenoid cavity. And then you have, it holds it in the joint in place. This is a picture of a normal joint, and this is a picture of the frozen shoulder. You can see that it's red and inflamed and just irritated. The causes. There are no known causes for this condition. Thick bands adhesions develop over time, and it results in less synovial fluid. The synovial fluid is just a lubricant for the shoulder joint, so without this lubricant, it becomes difficult to move and it becomes stiff and painful. It worsens slowly with time, and it's most common in females that are 35 to 70 years old. It also appears from recent shoulder surgeries. Just because you're unable to move it, just say you have a rotator cuff repair, you're not moving your shoulder because you just had surgery, and that can lead to adhesive capsulitis. It also is common in diabetics. 10 to 20% of diabetics have adhesive capsulitis, and then other health conditions such as thyroidism and stroke. It also can just come from immobilization of the shoulder, just not moving it results in thickness of those bands. And when looking for this in a patient, you look for dull and achy pain, pain with movement, usually the outer part of the shoulder, so this area and the upper arm area. Stroke is also a risk factor for this condition because movement of your arm may be limited. Also, researchers aren't sure why other diseases and conditions increase the risk for developing this condition, but they do know that thyroidism is linked with inflammation and muscle weakness, which could be the reason that most people with thyroidism have this condition. For the signs and symptoms, they all depend on the stages of the condition. So there are 3 stages. You have the freezing stage, the frozen stage, and the thawing stage. The freezing stage is when it first starts and it's stiff and painful. The pain slowly increases in this stage, and it worsens at nighttime. It's also inability to move the shoulder increases, so it just gets stiffer and stiffer as time goes on. And then it lasts approximately 6 weeks to 9 months. On this picture, you can see the different stages. We'll go in depth to those. And then you have the frozen stage. So this one is actually, the pain begins to lessen. I would think that it gets harder or the pain gets worse, but it actually eases up during this stage. But the shoulder is still stiff. It actually is stiffer than it was in the freezing stage. And in this stage, it's more difficult to function, and it lasts from 2 to 6 months. This is another picture of a normal one that's not inflamed right here, and then this one you can see is thick and red and inflamed, and this is actually the frozen stage. This is a picture of the inside of the shoulder. So here, everything is intact. These are connective tissues, they're all intact, but as you can see, it's red and irritated in the inside, and this is a shoulder that is severely inflamed. It's a little blurry, but. And next we have the thawing stage. In this stage, motion slowly improves, it returns to normal motion, and you get closer to your normal strength. In this stage, it takes 6 months to 2 years. So in this stage, it basically starts getting better. For testing measures, so Most of the time they just do examination. You just look for pain in any motion. So taking the patient through active range of motion, passive range of motion, and then comparing the two. Most of the time with this condition, you have pain in both active range of motion and passive range of motion, and both of them are limited. And then you, of course, you take measurements just to compare each side. You can also get x-rays, but this is not the first go-to for this condition because x-rays show dense structures and they may show arthritis, which is not this condition. You also have MRI and ultrasound. They are better quality, but they aren't required for this condition. And they are better for rotator cuff tear versus adhesive capsulitis. For special tests, you have the Atlas test. As the picture shows, it's just reaching behind your head and then reaching the opposite way behind your back. And it will be a positive test if it's an asymmetrical reach. So you're not able to get the same amount on one side. That would be a positive test. But mostly, the first thing to do is just take the patient through all range of motion and look for pain. For the rehab process and protocols, this is mostly a non-surgical condition that can be treated just with physical therapy, and that just includes range of motion and stretching. However, this may take up to 3 years to see a change or to be completely healed from the condition. The focus in therapy is to control the pain, restore motion, and to gain strength back into that joint. It is important to take care of other health conditions. For example, if a patient is diabetic and their A1C is elevated, developing a plan to improve the A1C would help work on adhesive capsulitis as well, because diabetes is a part of adhesive capsulitis. Also, steroid injections is another option. It's an anti-inflammatory. Since the joint is inflamed, then some doctors do anti-inflammatories. And then you have hydrodilatation. It is sterile fluid into the shoulder and it's done by a radiologist, just cleaning out the area. And then for protocols, you want to prevent reinforcing poor scapulohumeral motions. Here are some examples of what we would do as a physical therapist to a patient that comes in with this condition. So here we have just a stretch. You may have seen it in your clinical, but the patient puts their arm in the door and they're just walking inside the door and outside the door, and it's giving a good stretch to the anterior part of their shoulder. Then you have forward flexion. As you can see, this is passive because, well, active assisted because the patient is actually moving his arm up instead of just going up by himself. You also have crossover arm stretch, and that's just the stretch that we do mostly to stretch this condition. And then you have surgical options. If conservative treatment fails, they do manipulation, which is just going in and moving the joint for the patient while they're sedated. And then you have shoulder arthroscopy. And that is, in this picture, this is one that is clean, and this is after the procedure, and then this is before they went in and scoped the site. As you can see, it looks way better. And then post-surgery, PT is mandatory. The recovery process is about 6 weeks to 3 months, and it's a very slow process. Physical therapy is very important in this condition because it can happen just from being still. The biggest factor is mobilizing the joint. And then for differential diagnosis, so for adhesive capsulitis, you usually have pain in all motions versus bicipital tendonitis. You see that it has overhead motions. So if a patient comes in and they're saying, well, I only have pain with overhead motions, then it may not be adhesive capsulitis versus if they come in and it's like everything hurts. Also, if they come in and you say, can you point to your pain? And they just say it's up here, but they can't say like it feels like it's right here, then that's most likely not adhesive capsulitis. Most people with this condition cannot point to their pain. Also, the age is 35 to 70 versus bicipital tendonitis, which is 20 to 45. For the likely outcomes, you have most patients have generally good outcomes and reduced to no pain. Also, improved range of motion. Some patients have insufficient range of motion even years later. and some stiffness. This is common in diabetic patients and the condition may return. Just because, like I said, it can come from just being still. And if you're being still, it may come back. So it's important to always move with this condition. Well, I'm gonna click on the video after questions. So we'll recap here, and here are my references. Are there any questions?
I have one. So since there are no known causes, does it usually come from like, does it usually come gradually and just pop up, or is it more so a secondary?
It can come gradually, but it is most common to be a secondary to another condition. So like if you have surgery, you're being still. If your shoulder is just hurting from something else like a rotator cuff tear, you're being still, you don't want to move your shoulder. That's creating stiffness of that joint and it's getting inflamed from just being still. So yes, it can come gradually, but it is most likely due to something else.
I have a question.
I got a question.
What is the capsulitis?
I said I had a question.
The capsule pattern for adhesive capsulitis is external rotation being most limited, then you have abduction, second to most limited, and then you have internal rotation, which is most limited, or at least limited. And it's 3-to-1 ratio. Any more questions?
I do.
Yes, ma'am.
This is more of an opinionated question because, like they said, they don't have any like real understanding of what it's caused by. But why do you think that people with diabetes are more likely to get frozen shoulder? I would think stroke victims because they're not able to actually move it. But why do you think it's more so diabetes in your opinion?
I do know diabetes can be linked with muscle weakness and collagen, and I know there's a lot of collagen in the shoulder joint, and I know that diabetes is linked with weak collagen and impaired collagen. So I think it may just be because diabetes comes with that, and that's a part of adhesive capsulitis. Any more questions? Okay. Now my link is working, so I'll play this short video just to recap everything we talked about.
So make sure that you know all of those associated medical diagnoses with make sure you know the associations of the medical diagnoses that are associated with frozen shoulder. What I've seen on the National Physical Therapy exam, mostly is CVA and diabetes, either one or two, being highly associated with frozen shoulder. However, there are others, such as if the person doesn't start to move, rotator cuff repair. One that I see a lot is status post mastectomy. Anybody know what a mastectomy is? Okay, everybody know what that is? Okay. So yeah, so all of those are hallmark, but make sure you go back and familiarize yourself with the other ones that were in the video as well, like hyperthyroidism, Parkinson's disease, exactly. Because you will see that again. So good job, excellent job pointing those things out. So you beat me to a lot of things that I would actually talk about. Now go back to so now if we talk about soft tissue and we talk about specifically the rotator cuff muscle, which muscle did I mention that if it is taut, it can mimic frozen shoulder? Because the patient will likely present with the same capsular pattern as frozen shoulder. So rotator cuff muscle that I mentioned, that if it's taut, it can mimic frozen shoulder, but the patient may not actually have frozen shoulder. So you have to assess this muscle. Subscapularis. Did you find it in your notes?
Yes, sir.
Good job. So, I'm just gonna put a little line on here, taut. Why subscapularis?
Because it does need a rotation.
There we go. Because it does give you rotation, internal rotation. So if it's very taut, then that person's gonna present with a capsular pattern, that mimics adhesive capsulitis. All right. So good job with that. Now let's go back to our interventions. Go to your intervention slide. Good special test. So keep going. All right, now, so when we say crossover arm stretch, so when we think about our exercises, we have to know why we're doing our exercises. We have to know the why to what we're doing. So when we say crossover arm stretch, which portion of the joint capsule is being stretched?
Posterior.
So make sure you know that. So whenever you're doing something, know what and why you're doing it. I'm saying that because you can see this on the exam, on the written exam. Okay? So make sure you know that. Good. All right. So whatever we do, we want to know the why behind what we're doing, because that's what makes it skill. Now, if you don't know the why behind it, then it's not skill therapy. But what makes what we do skill therapy is knowing the why behind it. All right. So you go and you practice in an acute care setting, and the physician sends down some orders and say, perform a passive range of motion on this patient who's intubated. And you say, and some people say, oh man, passive range of motion is a skill therapy. They can get the nurses to do that. But based on what you learn in therapeutic exercise, is passive range of motion skill therapy? Yes, because you know the purpose behind it. So you know the benefits of it. You know the science behind it, right? So you learned all that in your theories class, right? So now, because you know the science behind it, you know the why you're doing it, that is what makes it skill therapy, okay? So I can put you on a plinth up here, right? And I can do something to you crazy. All right, I can just take your arm to horizontal adduction and say, I'm just moving it. But it's not skill if I don't know the why behind what I'm doing. Now it becomes skill when I know the why behind what I'm doing, and I'm able to verbalize that. Go to where you talk about the stages. Okay. Andrew, how does patient education relate to the content that's on this slide?
Kind of just teaching them the stages they're gonna go through and what they're gonna feel during that stage, and kind of just what they'll expect.
Yes. Thank you. That's what I was looking for. You see? But I kept going till I got to what I was looking for. So it's going to be very important that when a patient comes to you with adhesive capsulitis, that you educate them on the process so that they understand what it's going to take and what they're going to have to go through. That is not going to be an overnight fix. Okay? And also for you to set realistic expectations and goals with the patient. Okay? All right? And so there's going to be patient education is going to be very, very important. So now this patient knows, okay, this is something that I may have to deal with for a while before seeing it in progress, so that they don't get frustrated with physical therapy with unrealistic expectations, right? And so they go to physical therapy for a month and things are not significantly improved. Well, that's expected because you got to go through the process. You got to go through the 3 stages. And so now you want the patient to understand that, all right? And if they don't understand that, they can have some unrealistic expectations. And we don't want to ever create those unrealistic expectations with our patient, okay? So patient education is going to be very, very important. So now you know how to educate your patient based off this presentation, right? If you get a patient who comes with adhesive capsulitis.